Everyone, we are going to be jumping into our very last presentation for today, and that is going to be medical assistance in death and dementia care, current practices and considerations. For anybody who's curious, in the other breakout room, the Care Partner 1, the topic is If I Knew Then, Navigating the Move to Long-Term Care. So give a second if anybody is wanting to jump in there, or if anybody there wants to jump in here. But I'm going to get our last presentation up and ready. So let's move all this, everything. All right, so again, our last topic, medical assistance in death, or MAiD for short, and dementia care, current practices and considerations. So here we have Dr. Trouton, who has been committed to social justice and patient choice throughout her career. She completed medical training at Queen's University in 1990, a residency in Calgary, and a master's of public health from Harvard. She's a clinical professor in the Department of Family Practice at UBC, as she was based in Victoria, BC for many years, teaching and establishing a clinic for women's health. In 2016, she added MAiD to her practice. She co-founded the Canadian Association of MAiD Assessors and Providers, or CAMAP for short, and is on the board as past president. Now based in Ontario since 2022, she's a clinical instructor at U of T and a clinical associate at UHN and WCH in Toronto. She's a member of the Ontario Coroner's MAiD Death Review Committee and is involved in the development and leadership of the regional and national initiatives about MAiD. Unfortunately, Dr. Trouton is unable to join us live today. We are going to be watching a previously recorded presentation of hers. So I want to let individuals know if you do have questions, unfortunately, we're not going to be able to answer them live today. However, we are happy to pass them on to Dr. Trouton after today's presentation to make sure they are answered. So everybody give me one moment just to grab the video up and we're going to get into it. Should probably make sure that my screen is, or my sound is also shared as well, so we can also hear the presentation. There we go.
Hello everyone and welcome to today's session on assisted dying in Canada. I'm Konia Trouton and I'm so sorry that I can't come with you in person, but I'm happy to be able to work with you today. The session, as you know, is recorded, so what I'm going to do is provide my email address so that you can contact me after this session if there are any dangling questions that are not addressed throughout the presentation. Just a brief land acknowledgements, which I know that you've heard a little bit, but I think it's really important to acknowledge our responsibility to understand, respect, and support the diverse Indigenous nations and their ongoing relationship with the land, because reflections shape a more informed future. With that, I'll just make a couple of disclosures that I am the past president and co-founder of CAMAP, and the approach to MAiD assessments that I will be describing is outlined in the Canadian MAiD curriculum, which is available to nurses, nurse practitioners, and physicians. So those of you who are interested, please look into that. I've written my email down here, so please take a note of that if you would wish to contact me afterwards. The outline for today is to look at Canada's law and the international context of medical assistance in dying, look at the eligibility requirements for MAiD, specifically in the context of dementia, go through the application and assessment process, describe the event or the procedure, and look at some ways that you can support the steps of MAiD. So our Canadian law began actually in 1993, so quite some years ago, when Sue Rodriguez made a challenge to Canada's Charter of Rights and Freedoms. The ruling at that time was 5-4, that her rights were not violated, and as a result, she committed suicide. Now, she had ALS, for those of you that remember. In 2015, two individuals brought forward a second challenge to Canada's Charter of Rights and Freedom. One had ALS and one has spinal stenosis, so they were both disabled. And the ruling was unanimous that the fundamental rights were violated. So our law in Canada is a response to the Supreme Court decision. Bill C-14 is the name of our law. Assisted dying is legal in several other countries in the world, and every 6 months or a year, there's an additional country that's investigating it or considering it. So you can see For example, in England and Ireland, they are currently developing some criteria whereby it might be possible. You can see in Australia that it's recently been legalized, and in 11 of the US states. So overall, 300 million people live in places where it is legal. There are different ways it's come to be legal in those countries, but nevertheless, it is becoming an overwhelmingly more common activity. So MAiD and dementia, is it possible? Well, Canada does annual national reports on MAiD, so we can know from that medical assistance in dying has been provided to people with dementia. Not all reports, though, are in the same layout. So people have been found to be eligible after a diagnosis with dementia and found eligible. You can see here, this is the 2023 data. So this came out in 2025. So there's a little bit of gap between when the data are available to be seen by the public. And you can see that in 2023, 81 people were considered to be in track 1 and 25 people were considered to be in track 2. So it was 106 people with dementia who did have assisted dying in 2023. Now, interestingly, in 2024, the data from the 6th annual report shows that 368 people with dementia had medical assistance in dying. So that was quite a jump, really, from 2023 to 2024. So we know that there are many, many more people living with dementia than have assisted dying, but nevertheless, it can be done. Some of you will be already primed to the idea that Quebec has a specific legislation that was passed in October of 2024. Excuse me. One must be a Quebec citizen with Quebec insurance in order to take advantage of this. I've underlined in gray advanced requests for medical assistance in dying, but if you look on the Government of Quebec website, you will see their criteria for the advanced request. The lead organization for this is the Association Québécoise pour le droit de mourir dans la dignité. Very important organization. And so someone who is diagnosed with Alzheimer's can specify what features show that they have intolerable suffering and at what point they should be identified as meeting the criteria for medical assistance in dying. So as a result of that legislation in October 2024, there are over 1,500 people who have already registered on that database. It may spill out to the other provinces. We do not know. There has been a national referendum on this, but I did want to alert you to the idea that there is such a process in place in Quebec. For the rest of Canada, and for assisted dying, as opposed to advance requests, it is the same in every province and territory, with Justice Canada and Health Canada holding that responsibility. So medical assistance in dying, if I'm already confused you by the acronyms, the medical assistance in dying, or MAiD, is from the 4 words, medical assistance in dying. So I've outlined that on the left at the top. And it's providing eligible people the option to end their life with the assistance of a physician or a nurse practitioner. It is an exception to Canada's criminal code, and the law I told you a few minutes ago was Bill C-14, but it was replaced in March of 2021 by Bill C-7, so that allowed even more people to have the opportunity of having an assisted death. In Canada, MAiD can be given either as an intravenous or as an oral medication. In many other countries, it is only the oral medication that is allowed. For example, in those US states where it is permitted, it is only oral. Now, in Canada, the requirements need to be confirmed by 2 assessments by a physician or a nurse practitioner. 3 of those are straightforward. You must be an adult, 18 or over. You must have Canadian health insurance, so you cannot be a tourist. So you must be eligible for Canadian health insurance. And it must be a voluntary request. No coercion, no substitute decision maker, no power of attorney, no executor, you. It's a voluntary request. The more complicated aspects of the assessment are the grievous and irremediable medical condition and the capacity to make medical decisions. So the 4 general conditions Okay, that's an easy way to remember it. 1, 2, 3, 4 with the focus on grievous and irremediable condition. There are 3 elements of the grievous and irremediable condition. First, that you have a serious and incurable illness, disease, or disability. And generally speaking, once you've been diagnosed with dementia, it is serious, it is incurable, and it's a disease, illness, and disability. Second, you must describe how you are in an advanced state of irreversible decline in capability or function. So that means a change from your baseline so that you're in an advanced state of irreversible decline. And lastly, you need to describe how the disease has made you, or how the advanced state of decline has made you experience enduring suffering that is not tolerable, that cannot be relieved by any means acceptable. So you don't have to have a fatal or terminal condition, but you do have to have enduring suffering, and you do have to be in an advanced state of decline. One of the questions that I think could be asked, but was not on the frequently asked questions that you submitted before today's session, was, am I going to be found eligible? And I think that's an incredibly important question, because being assessed for MAiD when one has dementia is not easy. You cannot plan to have MAiD if you're not found eligible. So you must be found eligible first and then plan to have an assisted death. Being found eligible may take more than one assessment, and each assessment may take some weeks or maybe some months to determine whether you are in fact eligible, because you may not have tried all the elements to relieve your suffering, including palliative care, disability supports, medications, trials, for example. Okay? And not all nurse practitioners and physicians who include MAiD in their practice will feel comfortable or will feel that they have enough skills to assess for dementia. Okay? So having dementia and having an eligibility assessment may be difficult. However, if I work through this with you, hopefully this will improve your ability to understand what can be expected of you. So, in your own words, what is the serious or incurable illness that you have? So first of all, you need to know yourself that you have dementia. Can you describe the impact on the illness that has led to some irreversible decline in your function? What suffering have you experienced? Do you have any trouble making medical decisions or weighing out options? Okay, so the person must answer for themselves, but those are the types of questions that one can expect. How is a physician or a nurse practitioner going to evaluate capacity? Well, capacity is limited to the specific context, right? So it's specific consent for a defined procedure. And so the procedure in question, of course, is assisted dying. So the way we would evaluate that is communication. Are you able to communicate why you want MAiD? Are you able to communicate what is your disease? Are you able to understand how this affects your functioning now and later in the future? Are you able to appreciate what different management techniques or options are out there? And are you able to rationalize why those options have worked or not worked? So those are ways that we assess it. Now, sometimes the physician or nurse practitioner would like to have a third assessment to make sure that we've assessed your capacity appropriately. So usually involved in the MAiD assessment would be a geriatric psychiatrist or a neurologist, somebody who's familiar with your condition. The capacity assessment must be close in time to the provision of MAiD, because if they assess that you're capable now, but then you don't actually put in a formal assessment for MAiD until a year later, your capacity may no longer be intact. So it's really important to have that capacity assessment either ongoing or close to the time that you're planning on having MAiD. So if your loved one is planning on going through this process, recognize there could be several events. Second issue, is death reasonably foreseeable? Now, on some of those data I showed you, there's something called track 1 and track 2. So that is because of this thing called reasonably foreseeable death. If someone is likely to die soon because of their condition, it generally means that their death is reasonably foreseeable. The legislation requires that both assessors need to determine if a death is reasonably foreseeable. Second condition that is important to exclude is a mental disorder. So if a mental disorder is the sole underlying medical condition that leads to one's request for MAiD, it is not possible to be found eligible for MAiD. That legislation is coming up for review next year, and so we may see some differences on that. So about the death reasonably foreseeable. If somebody is found to be track 1, there are two things that then occur. MAiD can occur immediately. So if you're found eligible by both assessments, then the person can decide immediately when they want to have MAiD. But if the capacity is at risk, then a waiver is also allowed to be developed. So a waiver is put in place, and I'll go into the waiver in more detail. So it's waiving the final consent for MAiD. However, if your disease is more slowly progressing and you are found eligible for MAiD, but your death is not reasonably foreseeable, then you're considered track 2. So that means there is a minimum of 90 days between the date of your first assessment and the MAiD provision, and an expert must be involved who knows the condition. And thirdly, the waiver is not a possibility. So the waiver is not a possibility in a track 2. So just to be very clear, is death reasonably foreseeable? Most of the time, Alzheimer's disease and dementia is usually considered track 1, but for some slower forms of dementia, it may be considered, or your assessors may find that it's track 2. And just to be very clear, I've worried some of you by alluding to the mental disorder, but dementia is not considered a mental disorder. Dementias are neurological disorders and permitted under the current legislation. There's some very specific wording from Justice Canada about this in March of 2021, and says very clearly that other conditions that affect cognitive abilities, such as dementias, are not considered a mental illness. Okay, so we're clear. So what about the application? Assuming that someone wants to go forward with an assessment, the process starts with a patient, and these people are called requesters. This is a term that's been coined by Health Canada and adopted almost across the country. It's helpful to either phone directly to the provincial line or ask your nurse practitioner or physician to do an assessment or refer you to a clinician who can do that. The assessments are very often done in person. Sometimes they're done by Zoom, but in the case of dementia, I would say that most of the 90% or more are done in person. I put some numbers here for you for the MAiD coordination, so please just take a note of what's relevant in your province or territory, and you can always look this up online, but I thought it might be helpful to have that in front of you. Okay. At some point along the process, and different provinces require it in a different sequence, but there is a written request that is required prior to having a MAiD provision. The forms are different in each province, but they contain the same information. So you'll notice here that I've put the Ontario, the BC, and the Alberta ones on. The request does require a witness. So you'll notice that at the very bottom on the right-hand side, that one would indicate that one is either a family member, a volunteer, a friend, neighbor, hospital, or care staff. If you are likely to benefit from someone's will, do not be a witness for their request for MAiD, because it would negate their you being an independent witness. It might indicate some kind of coercion. Okay, so if you're likely to benefit from their will, do not witness it. And hospital or care staff, if you're in one of those categories, you can actually write down as a witness, because it does not mean that you agree. It just means that you were present when the person signed the form. If you're really stuck, there is a list with Dying with Dignity in almost every community in Canada of volunteers who will be able to help you with the witnessing. So the MAiD assessment itself, it's really important for us to determine that there has been no coercion. And so some of the assessment will be done by the person on their own. Okay, does the person have the capacity to make the choice? Can they explain all those elements? Have they tried all reasonable methods to relieve their suffering? Once the assessment is complete, then the physician or the nurse practitioner will indicate the outcome of the assessment and the next steps. They might say something like, "No, I'm so sorry, you're not eligible." They might say, "You are eligible, completely, absolutely sure." Or they might say, "Not yet," that you are possibly eligible, but you're not quite experiencing enduring suffering. You're not able to explain an advanced state of decline. So they might delay or postpone it and say, "Not yet eligible." So one of those outcomes is possible. Why is that? Because there are some risks of MAiD and dementia, and we have to be aware of that as the assessors. Because you all know this, that the disease itself can involve sudden changes that are worsened by other factors. For example, if you get a severe infection, or if you get a lot of stress, or you have a sleepless several nights, that may affect your perception of suffering and may reduce your insight into the next stage of your illness. So the disease itself may cloud your ability to perceive things well, or maybe even to explain things. There might be some family influence around MAiD and dementia, because your family worries about you, right? So they hesitate about timing of when this might happen. And sometimes the family is able to read between the lines better than the clinician who's assessing you can, because they know you well. So they might feel your capacity is better than it appears. And clinicians, when they hear about MAiD and dementia, they might decline to do an assessment because of lack of training or professional risk. Because if the assessment was not thorough, they might lose their license to practice. And if the assessment was not in accordance to the law, they may face imprisonment. Okay, so these things are unlikely to happen to the clinician, but there may be just a delay. Okay, so risks of MAiD and dementia for all people involved. Losing capacity is a big worry in dementia. Some issues are related to end-of-life planning can be done early. So the MAiD assessment process might be one of the final stages, but there are other ways that you can plan for the end of your life that can be done early, such as do not resuscitate orders, or setting up a will, or making sure that you have made arrangements for your physical body. Capacity is needed to engage in the assessment, so we do need to make sure that there is still capacity, and that you can still plan. So the timing is very tricky. So therefore, there might be better times of day or days of the week to discuss an assisted dying, or to arrange for an assessment. Because sometimes there might be an awareness of the disease, but not of advanced decline. You might be able to not be able to describe suffering. And so that way, that is the reason that most assessors will assess dementia over several months, so we can get a better idea of the trajectory of the decline and the way that you express yourself. Once you're found eligible, after 2 separate and independent physician nurse practitioners, the MAiD can be planned. So most assisted deaths are at home. Most assisted deaths are by intravenous. All MAiD deaths are reportable to Health Canada, and sometimes that's through the coroner, sometimes it's through a regional program, and sometimes it's directly, but they are all reportable. For some people, they choose an assisted death because it's an opportunity to say goodbye when all of the loved ones are in the room at the same time. And it's a target for people to know, I'm going to be dying on May the 1st. So before May the 1st, I want to make sure that they have reconciled any discord in my family, or anything like that, any loved ones that you want to reach out to that you haven't reached out to in a long time. There's a possibility to integrate some spiritual elements into the end-of-life journey. And for many, it's a celebration of life, but the person is present at their celebration of life. So most people find that if they choose MAiD, they've done it because it's a way to take control of their own care and express their own wishes. So how do we set a date for MAiD? This is really difficult for most people. Okay, sometimes we want to wait for specific events. Sometimes there's a specific birthday. Sometimes there's a specific birthday, like that dingle that just came across. Sometimes there's a new grandchild. And so sometimes those dates are really important for you to reach before MAiD occurs. And it requires ongoing discussion with the MAiD provider, because one of those 2 people who assessed you has to be the person who provides the assisted dying. It cannot be delegated to another person. So usually close to the time of setting a date, there would be an assessment for capacity to make sure that that's still intact. Most people, in my experience, decide their date about 2 or 3 weeks prior when suffering is really intolerable. But for others, it might be a longer duration, specifically if there's a grandchild that's expected or something like that, several months in advance. If there is a risk of capacity between today when you're found eligible and in a few months when you want to have MAiD, if you're going to lose capacity in that time, there's something called a waiver of final consent. And I know many of you have heard about this and are very anxious to know more about it. What is a waiver of final consent? Well, first of all, the MAiD provider, so one of the two assessors, explicitly tells you that there's a concern for a loss of capacity between today when you're eligible and in a few months' time when you want to have MAiD. So if they're concerned that you're going to lose your capacity, they'll tell you. There's a written agreement between two people, the requester, the person who wants MAiD, and the provider, the person who's going to give MAiD, to consent to the provision of assisted death on a specific future date. So a very specific future date has to be decided. This agreement between the two people cannot be delegated to someone else. So if you agree with Dr. Smith that you're going to have an assisted death on May 1st, Dr. Smith cannot delegate that to Dr. White. It's not possible. What you're doing is waiving the requirement to give express consent on the day that the MAiD medications arrive in your home. Okay? So normally when the MAiD medications arrive in your home, you say, yes, Dr. Trouton, I recognize you. I would like to have MAiD. I do not want to deny this. I want it now. So that would be the express consent that we usually get, but you can waive that, right? You're waiving that final consent. The waiver of final consent is not permitted when something happens. Like you cannot, it's about a date. It's not about, I would like MAiD when I don't recognize my loved ones. I would like MAiD when I can't feed myself. I would like MAiD when I need to transfer myself off the chair. I would need MAiD when I need to be transferred to an institution. That's not a possibility. We're talking about a specific date, so you have to define a specific date on which you plan to have MAiD. And you're allowing the physician or nurse practitioner to give you the medication, even if you can't explicitly consent at that time. You can always refuse. You can always say, nope, I'm not ready, I don't want it. You can always say that. But it's sometimes difficult to maintain the capacity to give consent. Is it binding? So if you enter into this agreement with a physician or nurse practitioner, is it binding? No, it is not binding. The clinician can decide, nope, I don't feel comfortable providing assistance. The person themselves can say, nope, I don't want to have it now, and they go and withdraw the plan. And if the person's sounds or gestures indicate a refusal, so even if the person can't say no, but they withdraw, they turn away, they look like they're refusing, then the clinician will not proceed and is not legally allowed to proceed. However, if we get to that date of May 1st, a second waiver could be done if the person still has capacity to make another waiver of final consent, right? So it is possible to do a second consent, but we have to be very careful that capacity is still intact. Are they used a lot? Well, some clinicians will use it, but generally for a short period of time, so up to about 6 months at the most, but rarely longer, because it means that the clinician is committing to being there on May 1st when you want MAiD, and it's not some loosey-goosey date in the future, but it's a specific short time. So the window to say, yes, I consent to MAiD and I understand what it is short. The window to say no always exists. In many situations, from the people that I've worked with, it's very helpful to have a fixed date, location, and time so that you can gather, focus, plan toward that date, do the reconciliation that you need to, speak to all the loved ones that you really care about and making sure you have one-on-one time with them, and engage some spiritual elements into thinking about the end of life. What are some frequently asked questions about MAiD and dementia? I know some of you have submitted some of these earlier, and so hopefully I'll address most of them as we go along. Is MAiD for dementia currently allowed? Well, hopefully if you've been listening carefully, you'll recognize, yes, MAiD for dementia is currently allowed. It's limited and must be done earlier in the disease process because you have to be able to answer all those questions. Often MAiD is provided just before one transfers from home to extended and specialized care, right? So the timing of MAiD, in my experience, is just around that time when you're when the person who has dementia is getting to the point where they need more and more care because they're in such an advanced state of irreversible declining capability that they can no longer be managed at home. Does that make sense? So that is the point for most people that they have MAiD. So the exceptions are, of course, in Quebec, and I've alluded to that. So those of you that are in Quebec, you could be one of the people that signs up for an advance request. How is consent and capacity determined? So in general, the capacity is done by the nurse practitioner or physician who does the assessment. So most of us can recognize if people have capacity or not. And anytime capacity is a question, we bring in a third person, a third expert to be sure that capacity is intact. So again, capacity is the ability to provide specific consent to a very defined procedure. It's not general capacity, it's capacity for a specific procedure. What is your medical condition? How does living with it impact you? What management have you tried? And why have you chosen various options? Why have you chosen MAiD? Okay. Is consent required throughout the MAiD process? Yes, it is. Because there cannot be any coercion at all in the MAiD process. It must be a voluntary request, and it must be directed by the person who's going to, at the end of the day, have an assisted death. So it must always be directed by the person having MAiD. So the assessments, it also is required to establish the date for the MAiD provision. So consent is required even in establishing what the date is for the MAiD provision, because the waiver of final consent is signed not by the executor, not by the power of attorney, not by the substitute decision maker, but by the person requesting and planning to have MAiD. Can one plan for MAiD later in the illness? Well, this is limited really to Quebec. One is only found eligible for MAiD when there's advanced decline and intolerable suffering. So that's the tricky part. So the person having dementia will be a little later in their illness, but not so late that they've lost capacity. So they have to be in advanced decline with suffering, but not yet lost capacity. So it's a tricky little moment. Some people call it the 10 minutes to midnight, but it is a very small window where there is capacity, but still an ability to describe advanced decline and suffering. So therefore, it's wise to start the MAiD process early after a diagnosis. So one might not yet be eligible, but you might be followed by a MAiD assessor over a year or more. In my personal experience, I've usually followed people with dementia for an average of 18 months. When do you have to decide on an assisted dying? Well, first of all, you have to be eligible before you can even decide on MAiD. So it's worthwhile to go through the assessment process, and you may opt out of the assessment at any time. You can opt out and say, look, this is not for me. I'm learning more and more about it, and assisted death is not for me. And that's absolutely fine. But you must decide on having MAiD if you're found eligible when your capacity is still intact. Can someone set up MAiD for the future? Yes, but only if you have Quebec medical insurance and go through the process to get it on the provincial registry. My colleagues in Quebec have told me that this is quite a lengthy process, that this involves talking with your physician, identifying a trusted third party, having a lawyer involved, and making sure it is established within the provincial registry. So it is not a simple process. But those of you who are living in Quebec or are eligible for Quebec insurance could certainly start that process. It can only be made once the diagnosis is made. So those of you who are on the call who are worried that you might get dementia, you cannot put this process in place until the diagnosis is made. There was a national referenda that I was referring to earlier that occurred last fall, but no action has yet been taken by any other province on advance requests. However, one can and should have an advance directive. Now that's different from an advance request. What is an advance directive? Well, an advance directive can be written when someone is well or when you're early in the disease process. So any of us, even me, I could set up my advance directive now. It's not specific to one clinician, so that's good. And it can be used for refusing care. So I could identify what kinds of things I don't feel comfortable with in the care that happens to me when I lose capacity. I could say, never intubate me, never defibrillate me, never have me in the intensive care unit for longer than a day or two, never give me a vaccine anymore, never give me antibiotics. So I can specify what not to do when I have lost capacity. There's no specific date or time frame. And a delegated decision maker is involved for example, the power of attorney for healthcare, because that person can identify, is there such a thing written and when was it written? So an advance directive can be written, but someone's got to know where it is so it can be pulled into effect if one loses capacity. So a waiver of final consent versus an advance directive, just so you're clear. A waiver of final consent is for people who are eligible for MAiD. So people who are found eligible after 2 assessments, not just generally eligible, but eligible after 2 assessments, and they're capable of making a decision. So a waiver of final consent is very limited. It's an agreement between one provider and one patient. It's not used to refuse treatment. It is used to get an assisted death, and a date must be specified. The delegated decision maker is not involved. There is no executor. It is only an agreement between one provider, that is a doctor or a nurse, and one patient. An advance directive can be written when the person is well. So that's different, right? And it doesn't require that you're eligible for MAiD or not. It's not specific to one clinician and is just for refusing care. Okay, so there's no specific date and the delegated decision maker is involved. So the advance request is used for a competent person to request assistance to die when criteria are met. And this is Quebec, but for reassurance, it's also in Belgium, Netherlands, Luxembourg, Spain, and Colombia. It's written after the diagnosis, and it's a delegated person must be needed to trigger the assessment, because good if your name's on the provincial registry, but if your loved ones don't know that your name is up on the provincial registry, then who's going to trigger that assessment at the time? So it's really important that you identify a trusted third person, 1 or 2 people. There's no specific time frame, but it requires a certain format and a safekeeping. Okay. Lastly, I just want to turn to how do we support the steps of MAiD, because I know many of you are involved in caring for those with dementia and you want to be able to help. We can support those who want information and an assessment by providing them that information, looking up that information on the internet, looking up the 1-800 telephone number. We can listen to understand what's really going on. Is that person suffering? Are they experiencing an intercurrent illness? Is it that they are just worried about how their life is going to roll out now that they have this diagnosis with dementia? Are there other things that they're anxious about that we can put aside? Making sure that decisions are made with full information. So participating in the assessment as much as you can, listening to it, contacting people, writing things down. Helping with other non-MAiD end-of-life planning activities like the advance directives we were just speaking about, and being prepared for bereavement before and afterwards. So those are all ways that we as loved ones, as healthcare providers, can help with supporting the steps. Those of you that are healthcare providers might be interested in actually exploring this in more depth, and so you might want to take the serious illness conversation. It is a series of scalable communication tools that you'll learn about, and how to build confidence in talking about serious illness with your patients. The advanced care planning I alluded to earlier, but it does involve reflecting on one's values and wishes and talking with your physician and nurse practitioner. It's really important in any case to talk to your clinician about those healthcare opportunities that you want or do not want, and have them recorded in your medical records. If medical assistance in dying is not something you're interested in, it's helpful if that is recorded in your medical notes. If medical assistance in dying is something you're interested in, equally it's important to include that in your notes. But including your advanced care directives of what you do not want when you're in a certain frame of your health, it's important to write that down. Many of you might ask, should I bring up MAiD? Well, people do want to know about their illness, their trajectory, their prognosis, but they also want to know about options. So not only can you help them understand where that illness is going to go, what it's going to look like, over what period of time, if you know that, they also might want to know what options are there, like what way are they going to die? They might die, you might die from an intercurrent illness like a respiratory infection or a urinary infection or sepsis, something unexpected. But there might also be that option for medical assistance in dying, which is legal in Canada. So you can certainly bring that up. It's a factual statement. It's correct. It's been 10 years since we've had it in Canada. And bringing that up early will bring a strong foundation for decision making. So you can find out early on in the process whether this is something that aligns with someone's belief categories or not. So if it's ethically outside of their framework, good to know. Have it written down that is not something they want to know about. Recognize, if you're a healthcare provider, that providing information is not the same as recommending an option. If you're discussing natural death, this is what it might look like. Palliative care, this is what it might look like. Assisted dying, this is what it might look like. Providing that information is not the same as recommending. And redirecting a patient to the appropriate resource is one thing that you should do. If one is an assessor, and those of you who are nurse practitioners or physicians might be interested in this, or just so that all of you are aware of what the responsibility is that we carry as an assessor. We all recognize that it's a limited exception to the criminal code, and MAiD events are reportable by the assessor who provides MAiD. The MAiD assessors can be a nurse practitioner or can be a medical doctor, and all of us choose voluntarily to do this work. It's not a required part of anyone's job description. Most of us have taken the Canadian MAiD curriculum, which was put out by CAMAP. All of the assessors must ensure the correct application of the law and the safeguards to the law. The assessors must document the process as if we are preparing for a medical legal case, so it's very detailed and it is a sacred responsibility. So please know that all of us take this very seriously, and it's an important part of what we do, but it's also a sacred part of what we do. Here are some references to some websites so that you are aware how to get more information. Dying with Dignity is a national human rights charity that many of you are aware of, and it allows the public to know about MAiD. CAMAP is the Medical and Professional Association of MAiD Assessors and Providers. It is also a registered charity, but that is where we get most of our information and updates. MAiD House is a nonprofit charity which is both in Toronto and in Victoria, and it provides resources for families. But across Canada, there's MAiD Family Support Society, which is a peer-to-peer resource, and this is another registered charity with MAiD. So depending on what your interest is in it. So I hope through the last several minutes, I've gone through you several new terminologies, and I just list them here so you have them. MAiD, Medical Assistance in Dying. You've got the MAiD application, the MAiD requester, the MAiD assessment, the MAiD provision. Then you've got RFND, which is reasonably foreseeable natural death, a really important distinction. You've got MD Sum C, which is not illegal in Canada, but you'll see next year. And then you've got the advanced consent, which is the waiver of final consent we spent quite some time on. For oral MAiD, it's also a limited use there because of the possible delay or failure of the oral MAiD. Then we have to have advanced consent for intravenous. Then we have advanced directive and advanced request. All right. So lastly, Canada is not unique globally. The laws for assisted dying are expanded right across the world, and we'll see this change over the next year. So how we choose to die sometimes reflects how we choose to live. So you can see why for many Canadians it's an important opportunity to have an assisted death. And so as individuals, as family, friends, and caregivers, we are all trying to find solace and grace in the tragedy that is dementia. Thank you.
All right, so that is the end of Dr. Trouton's presentation. Again, it was a recorded video, so there is not going to be a live Q&A session afterwards, just because they are not here to present. That being said, it was our last presentation for today. So if individuals are interested, you can connect with our team afterwards. We can pass on the questions to Dr. Trouton and they can follow up. But other than that, we would like to invite everyone back into our main room, our main session, just for some final words and some wrap up. So if you're able to pop yourself in there, please feel free to do so. Otherwise, I'll just start slowly moving everyone myself. All right, so thank you everybody so much for joining, though. It was definitely a great day filled with lots of information. We're very happy to have you all joining us. And yeah, if you can just slowly make your way into the other room.